So I'm just going to record it too, so that way, people are not, whoever is not able to join, they could listen in at a later time.
Yeah, absolutely.
So it's almost 3 minutes past 4. So should we start? If everybody is okay, we can go ahead and start. And people who wanted to join, they can join later on.
Sure.
Okay. So good afternoon, everyone, and welcome to Manofa Health Seminar. And we are very pleased to see all of you here. And my name is Intu Nair, and I am the Manofa president. And today we have a great speaker, Dr. Shaili Shah, who is a cardiologist from Ascension, St. Vincent, Florida. And welcome, Dr. Shaili Shah. Our moderator is Sunitha Menon. She's Manofa vice president. I just wanted to give a brief introduction to you because there are a few people from outside of Florida who also have joined. She's an RN working in Accent St. Vincent. She has several qualifications, which, there is a list, so I'm not going to go through all of them. She is a very passionate healthcare, provider, and she has over 30 years of experience in healthcare. And she is also a clinical instructor in several multi-specialty hospitals. Welcome, Sunitha. We also have a lot of people who joined today, and I would like to welcome all of them, especially our Manofa members, and also people who joined from outside of Florida, which is North Carolina, Atlanta, Michigan, Chicago, and Dallas, and a couple of them from Seattle. So it's a wide set of audience we have today here. I just also wanted to recognize a few of the people who worked behind this to make this happen. Especially our secretary, Simple Jacob, and also Vice President Sunitha Menon, and also our wellness directors, Nita is on the line, and also Sandeep Vasudevan. That's all I have for now, and Sunitha, floor is all yours.
Thank you, Intu, for the wonderful introduction. Good afternoon, everyone. I'm Sunitha Menon. I'm a nurse practitioner. I also work at Ascension St. Vincent's Hospital, Riverside, and the Orange Park as a cardiology nurse practitioner. And I welcome Dr. Shaili Shah and all of you for health seminar presented by Manofa Wellness Team 2023-2024. So we are excited to have you on this Zoom platform, and we can't wait to hear from you. And to talk about Dr. Shaili Shah, it's our honor and privilege to have you on the Zoom platform to talk to us. We thank you so much for that. Dr. Shaili Shah is very passionate about improving women's heart health and works very closely with maternal fetal medicine to provide individualized care and treatment plans for at-risk patients before, during, and after pregnancy, where most of the regular cardiologists are afraid to touch any maternal or high-risk a pregnant mother, especially in dealing with a cardiac condition. And that is Dr. Shaili Shah's passion, and we are very proud of it. As well as she's a strong advocate of preventing heart disease and focuses on all aspects of heart care from prevention to early detection and treatment. And outside of work, she loves to do oil painting, gardening, and play with her toddler. Dr. Shaili Shah is a board certified in internal medicine, cardiovascular disease, nuclear cardiology, and adult echocardiography. She leads the Women's Heart and Prevention Clinic for Ascension St. Vincent's at St. John's Hospital. So anywhere near that 210 area, St. John's County, she's there for your any type of cardiac care, especially her passion is women's heart health. She completed her medical school in India, and she was trained at Cleveland Clinic, Ohio for internal medicine and completed her cardiology training at Medical University of South Carolina, Charleston. So Dr. Shaili Shah will be talking to us about South Asians and cardiovascular risk. And let us hear from her. The Zoom platform is yours, Dr. Shaili Shah. Thank you.
Thank you, Sunita. I'm flattered. That was okay. That was fantastic. All right, so let's get started. South Asians and cardiovascular disease. The fact that this is all, a whole separate entity means something. It is for a reason. And this is who we are, South Asians. We'll talk about it, which countries constitute. We'll talk a little bit about history. We'll talk about each and every disease that entails and pertains to us, the risks, why things happen, and things to look forward to. And as I mentioned before, if there's any, if there are any questions, concerns, you want to stop. If there's too much medical jargon that you don't understand, please stop me and then we'll discuss more. I'm happy to answer all your questions. All right, so a little bit about the history, because I found this interesting preparing this slideshow. So I was like, oh, let me just share this. So yes, 7 countries, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, Sri Lanka. These are the people from here are all South Asians. And just a little bit about immigration, because it pertains to what generation immigrants we will see in medical field and, where do we, who we are. So it all started from India in 1920s. It was all Punjab. It was in 1800s. After that, we saw more in 1966 to 77. I'm sure some of you guys fall in this when there were highly skilled professionals, there were physicians who came to the US. I mean, these are big numbers, 20,000, 25,000. Then the third one was more in the 80s, where we can see some of our extended families, because these are all people coming in to meet their other family members who migrated before. So immigration was pretty easy that, until that time. And of course, now we know how difficult things are. So according to the US Census, by 2010, there are more than 3.4 million South Asians living in US. And 80% of them are Indian origin. And 6% are more than 65. These are 2010 US Census statistics, so pretty accurate. And, we can see how prevalent things are. And this is just, how densely certain states are. We can see in Florida, we have a lot of pockets where South Asians, darker areas are where, there are concentrated South Asians, Houston, Dallas, areas of California, Northeast, New York, New Jersey, Connecticut, those areas. There are pockets in Chicago, some pockets in Michigan. So, I mean, we are technically everywhere, but, these are just some dense pockets that we see. And this is all based on, the percentage of immigrant population, what would constitute South Asians. So by almost, in next 2 years, we'll be 29% of all the people who immigrate. Of course, Hispanics are way more, but then when you think about it in next 30, 40 years, we are probably going to be more than any other immigrant population here in the US. Just few celebrities which were on the news, Siddharth Sharma and KK and a lot of other TV celebrities we know. Some of the other people. So basically, these people are those who died very, very, very young. And of course, they all had cardiac arrest, they had heart attack, some sort of heart problem leading to their death. Hence, we are giving this talk because, things happen at a young age. And just few facts that we need to know. That we constitute 2% of American population, 25% of world population, which we clearly saw in the next, 10 to 20 years, things are going to change. It's going to be way more. Unfortunately, when you see this number, it's just 2% of US, but we see that we constitute 60% of the heart disease here. And 25% of them happen younger than 40, and 50% happens younger than 50 years of age. So, which is pretty serious. South Asians, they tend to develop heart disease 10 years earlier compared to all other races. 44%, these are normal weight people. People say, oh yeah, you're skinny, you would never have a heart problem. These 44% of people, they have more than 2 risk factors, hypertension, diabetes. By risk factors, I mean, hypertension, diabetes, cholesterol, those kind of things, compared to just half of them in whites. And then diabetes, blood pressure, cholesterol, it all, again, along the same lines, it all happens at a much lower body weight compared to everyone else. And good thing is, more than 80% of these are preventable. So let's just talk about every, disease and just touch briefly on how things happen. And then we'll go a little bit about South Asians, how we are different and why things happen in South Asians more than anyone else. So coronary artery disease, meaning heart attack, blockages that you commonly hear. Just to give you briefly, I know you had a session last year, but just to a quick recap. This is a normal artery, perfectly fine, having all the good layers. But then what happens is when you have a lot of fat, does not mean that you are obese, but then you have a lot of body fat, meaning fat around your heart, and you have the risk factors. There's a little fatty streak. You can see fatty streak as early as 18 years of age. Once that fatty streak develops, which is within one of the layers of your blood vessels, your body cells come and try to eat it, and then they become trapped inside. These are the foam cells we're talking about, because your vessels, your body does not want fat here. So these macrophages, which are the cells that come to try to eat it, they become full, they become fatty, and it gets deposited here. Your body feels like, oh God, I need to just cover this up. And so there's a layer of calcium, which is the fibrous cap. In normal people, I wouldn't say normal, but in most of the people with the fibrous cap, you would have some exertional symptoms, but it's over a period of time when this ruptures. There's a clot that is formed. There, as you can see, there's a complete blockage. This is when you present with heart attacks, you present with cardiac arrest, you present with symptoms that we'll discuss later. And, just like the main big arteries of the heart, there's the left artery, there are 2 on the left. One of them popularly known as the widowmaker, which is your left anterior descending. If things, this is a blood clot, this is basically there's fat, it ruptures, there's a thrombus. So as you can see, the whole thing is blocked. That's when you have heart attacks. And then there's one artery on the right. So when people present with heart attacks, we do a heart catheterization in which we either go through the wrist or through the groin. And this is what we see, that there's, complete blockage of this artery where it should be a nice, thick vessel. Women, they present in a little different way than men. You would see, a typical male would have like chest pain radiating to the left arm. there would be some shortness of breath, but women, the amount of chest pain would be less. They would feel like, oh, I feel tight in my chest. I feel like there's a band, there's something, a pressure-like thing. But some of them just present with shortness of breath. Some people have more like, oh yeah, I have indigestion, but Tums don't take care of it. Some just have some jaw pain, heaviness in the jaw, arm tingling, numbness. Some people have cold sweats, dizziness, lightheadedness. And just a little bit, again, this is not just South Asian, like in general, women present like this. And again, there's an 80-80 rule for heart disease in women, pertains to every woman, that cardiovascular disease, including stroke, happens 1 in every 80 seconds. How common is that, huh? And 80% of this, as we spoke about, is preventable. Now, talking about just some facts about coronary artery disease, meaning heart attacks, happens at a younger age. Clearly, we saw it on our previous slide, how the celebrities we know, they died in their 40s and 30s, and some even in their 20s. It happens with low BMI. Skinny does not mean you're fit. You would never have a heart attack. South Asians, they have more number of vessels involved. Going back, remember, we saw that there's 1 on the right and 2 on the left. If 3 of them have blockages in them, we go for a bypass surgery rather than do a stent, which is open heart surgery, commonly referred to as open heart surgery. So South Asians, they're more likely to have open heart surgery because they almost always have 3 vessel disease when it happens young. Does that mean like there are no stents in them? There are, but this is just more common. And why this happens? Well, this is a normal heart. There's not much fat around. And then look at the amount of fat here. There's a fat around the heart. Unfortunately, with the genetic predisposition or things that are still under investigation, because now South Asians are, they have a big focus because of events happening much earlier. We found out that there's a lot of fat around the heart. Does not matter how, obese or not obese you are, there's a lot of visceral fat. Other thing, they have a lot of premature calcification. Remember, we spoke about fatty streak, foam cells, and calcium. So once there's calcium, there's a blockage. So there's a lot of premature calcification. Normally, you should just have calcium in your bones. But South Asians, for whatever reason, they have a lot of calcium in their arteries, despite having good controls of risk factors, which all brings to the genes we are born with. They have a lot of visceral fat, not just around the heart, it's around the abdomen, liver. We'll talk about this later. There's more inflammation, there are more inflammatory cascade that causes premature blockages in South Asians. And overall, the size of arteries that we have, it's much smaller than anyone else. So as you can imagine, if it's a smaller artery, the chances of blockages are much higher, and there's a higher degree of narrowing. We'll just briefly talk about the second risk factor. So that was heart attack. Now we are talking about diabetes. I'm going to explain to you a little bit about what is diabetes. Again, just a quick refresher from last year. I'm sure you had all these talks, but what is diabetes? The 2 big things, there's number 1, that's insulin resistance, meaning you have insulin in your body, but your body does not know how to use it. And that's most common type 2 diabetes. And then there's type 1, in which the pancreas, which produce insulin, they cannot do it. They have some issues with the pancreas, which is type 1 diabetes. And South Asians, they have the first one, the type 2 diabetes. And they have a lot of insulin resistance. And there's also a study that there's early decline in the pancreatic function. Sorry, a lot of medical jargon. Will simplify this. So whenever you eat a meal, it goes into your stomach, intestines, and then there's a lot of glucose, and the glucose level tells your pancreas, hey, make more insulin. Once the insulin is formed by the pancreas, it acts on your liver, it acts on your muscles, it acts on your heart tissue, it acts on everything. Basically, insulin tells them to use it. And so all the glucose level goes down. There's a good balance between what you're eating, the glucose, and what your body, how it uses it, and things are happy, things are good. Now, as you can imagine, if there's an issue with the pancreas, they do not produce insulin, which is type 1, then how much ever glucose you're eating, there's nothing. So you have to supplement them with insulin, the common type 1 diabetes, which is usually at birth, autoimmune, things that we usually don't get that much. Some people, yes, family history, but South Asians have the common type 2, in which there is insulin. Your body produces, it's perfect. There's glucose, tells your body to make insulin, but for whatever reason, either it's the high fat in your body, or it's how there's a little bit genetic predisposition that your body cannot use it. So there's too much glucose, too much insulin, they don't talk to each other, and there's imbalance. Your organs cannot use all the glucose, and so you end up with diabetes. So organs and muscles, they do not respond. And of course, the only way you can control is to eat less glucose, eat less carbohydrates. Just, type 1 diabetes, only 10%. Your body does not produce insulin. Can it be prevented? No, you're born with it, or there's autoimmune. Basically, there's a reason why it happens that you don't have any control over. The type 2, which we see 90% of people, in which your body produces insulin but cannot be used. Can this be prevented? Absolutely, yes. And so, exercise and what you eat, these are the two big things that help prevent it. A little bit about gestational diabetes, which will be more pertinent to women, of course. When you have high sugar levels when you're pregnant, it increases your chances of having diabetes down the line. So if you are having diabetes during pregnancy, your chances of having diabetes, it's 60% higher. And usually the levels are stabilized after birth, but then down the line, there's a high chance of developing type 2 diabetes. And again, how do you control this? Diet and exercise. I won't be able to see the chat box, so if anyone has any questions, just feel free to stop. So there's the study, what are a perfect name, Masala study, which was basically a study that involved South Asian people. They collected a lot of data, and basically the whole purpose of the study is we wanted to see what is the prevalence and what are the risk factors of heart disease in South Asian communities. So a lot of information in this talk comes from this study. It was basically South Asian men and women from two big sites. One was in California, one was in Chicago. These are the people, the countries we spoke about. They're 40 to 84 years old, and they need to speak Indian language because they were trying to get all the information. These are the people who did not have any heart attack. They did not have any heart problem. Never had a heart attack, never had a stroke, heart failure, nothing. These are just those people with risk factors, no disease. And they measured, they did, their height, weight, blood pressure, glucose, and they did their body fat, they did all the basic labs, they did genetic samples, everything was studied. They even obtained all, where they are from, all their medical history, medications, like sleep, diet, even health beliefs, because we all have some health beliefs, right, which guide our routine and day-to-day living. So they found that compared to all other races, South Asians, they have higher amount of insulin resistance, meaning type 2 diabetes. Again, they compared it to white, African American, Latino, who again eat a lot of rice like we do, Chinese American, like everyone, and there was high amount of insulin resistance. And there was a lower beta cell activity. Just to recap, beta cells, these are the ones in the pancreas, they produce insulin. So there was early decline in their activity in the cells producing insulin, and there was a lot of resistance. Both together, what happens? Well, men have the highest diabetes prevalence. Women, they have higher than whites, but it's similar to African American and Latino. But still, I mean, we are, pretty high in this. Not something to be impressed about. And, just to reiterate the same thing and hammer it, that we have lower beta cell function. We are not able to compensate for the massive amounts of glucose, which is carbohydrates we eat in our meals. Going to the third thing. So we spoke about heart attacks, we spoke about diabetes, so now obesity. Two types of fat. There's subcutaneous fat, visceral fat. Subcutaneous, it's the one that we see. We can pinch and see, oh yeah, I have a lot of abdominal, I have a lot of thigh, I have a lot of hip. That's all subcutaneous. Then the other one, it's visceral fat, which is deep in the body. Even if you're skinny, you could have it. You don't know. It's all surrounding the organs. This is the one that is problematic. This is the one that causes early heart issues because you cannot see it. So this is your subcutaneous fat, which is, we all complain about it day in and day out. But have you ever looked at this visceral fat, fat around your heart, fat around your abdomen, fat around all your organs? Unfortunately, you cannot see it, but causes issues. Talking about obesity, we always look at, the common BMI cutoffs that, oh, you are less than 25, that's perfect. I'm 23 and oh yeah, my BMI is, I'm healthy. But unfortunately, we definitely have way lower BMI cutoffs compared to general population. But unfortunately, all our physician offices use the regular BMI cutoffs, and we all fly with, we all pass with flying colors being under 25. Why so? Again, hammering the same point. We have a lot of visceral fat, a lot of fat between the muscles, a lot of fat around the liver, all that. So there's abdominal fat, yes. So despite similar BMIs, when you compare two people, one is South Asian and one is or Caucasian white, they both have same BMI. They both have similar weights, similar heights, everything. When you measure the body fat percentage, which is like you basically look at every, fat storage in the body. I mean, you look at this, unfortunately, we win this. South Asians have higher body fat compared to anyone else, despite the same BMI. Women have a higher waist-hip ratio compared to white. We'll talk about this. Oh, okay, here comes your waist-hip ratio. Waist-hip ratio is basically, as the name suggests, you divide your waist to your hip, okay? Apple is bad, meaning your waist is bigger than your hips, which is where we fall. Red is bad, apple is bad. But what is better? A pear. Your waist should be smaller than your hip. They studied waist-hip ratio, even avocado is better, which are very similar. But again, having a bigger waist compared to your hip, which is where we fall, then that is higher the waist-hip ratio, higher your risk of developing heart events. So when you think about where you stand, a simple fruit jargon helps. You don't want to be an apple, you want to be a pear. And I mean, to be honest, like people we see around, yes, this is where we normally are. We have thin, skinny legs. Hips are perfectly fine, but the waist is where the issues are. So again, risk of heart disease, way higher. Just a little bit about cholesterol levels. There's good cholesterol, your HDL, which is what we want. You obtain it from all the good fats that, your doctor tells you, avocado, almonds, olive oil, lean meats. And then there's the bad cholesterol, things that we love, burgers, fries, cheese. It's just, the bad cholesterol, unfortunately wins in us. So just, you all have lipid profiles done, just like, an annual screening at your primary care's office. I just copied a report from one of my South Asian patients. Things that I look for, again, red is bad. You don't want things to be highlighted in red. But remember, these are the cutoffs we use for every single patient. Does not matter if you're South Asian or white, but we know from all our prior slides that we definitely have much higher risk than anyone else. So again, definitely you don't want to be red, but you want to be way, way, way lower than the cutoff. So triglycerides, what are triglycerides? These are the fats that float freely. You've eaten so much that your body does not know what to do with that, and all that gets packed into fat globules, and these are your triglycerides. Normally, it should be less than 150. I tell my patients, half of them have high triglycerides. I'm like, anything that is white and tastes good causes your triglycerides to go up. What does that mean? White bread, pasta, in our case, rice, chapati, potatoes, salt, sugar, all these things are your triglycerides. LDL, bad cholesterol, definitely less than 100. Actually, the European guidelines say less than 50, and our new American guidelines, if you have even 1 or 2 risk factors, it should be less than 70. But again, we still use the less than 100. So I would strongly look at your lipid panel and make sure your LDL, your bad cholesterol, is less than 50. And your HDL, which is good cholesterol, higher it is better, at least 40, if not more. And then your total cholesterol, again, it's a calculated value, but definitely less than 170. So things I would focus on is to make sure your LDL, it is low, and your triglycerides, because triglycerides, it's very easy. The number one thing to reduce triglycerides is cut down your food, cut down your white and taste good foods. So South Asians, again, all the bad stuff, your bad cholesterol, total cholesterol, triglycerides, these are all high. Your good cholesterol, South Asians have low because of what we eat. 3 times likely to have low HDL. HDL is your good cholesterol. And 2 times likely to have high LDL. LDL is your bad cholesterol. Briefly touching on hypertension, 43% in men, 35% in women. Well, those who eat a lot of fruits and vegetables in their diet, they have much lower incidence of hypertension. Again, yes, we eat lots of fruits and vegetables here and there, but it depends how much you're eating in your meal. And hypertension in South Asians is much younger in onset. Little information pertaining to us women, menopause. So till you are menstruating, you have the estrogen, you have the progesterone. These are the hormones that prevent heart disease. They actually help you. So very few women you would see, unless they have really uncontrolled other risk factors, have heart disease when they're menstruating. It is with the onset of menopause that all your risk factors just double up. There's increased fat deposition with menopause. I hear my parents, my mother-in-law, everyone say, oh, ever since I started menopause, my weight has picked up. I cannot control. My body has just changed. That's because there's increased fat deposition. There's increased calcium in the arteries. From the Masala study, what we saw, of course, it was associated with higher BMIs, higher abdominal fat deposition. As soon as menopause starts, women start becoming bigger. There's higher hyperlipidemia, cholesterol levels were higher waist circumference. So remember the apple, the waist-hip ratio, that goes up. And so there's higher incidence of death, heart attack, everything goes up. So if you're menopausal, you have to be more vigilant. You have to be more careful because your risk of heart disease definitely goes way higher than before. And of course, there's increased fat deposition, there's increased incidence of diabetes because fat does not let your insulin work the way it should. There's type 2 diabetes in which there's insulin resistance. Family history, genetics, things again, which we cannot control, but things to be careful about. Things that should ring a bell that I need to see a cardiologist. I need to see a family practitioner. I need to get my risk factors under control. I need to be more cognizant with my health. Did your uncles, aunts, grandparents, anyone in your immediate family have heart disease? If your physician does not ask you this question, make sure you bring it up. This is a question I ask every single patient. Well, they say that, yeah, someone had this, but were they younger? Because if it happened to your aunt or your uncle in their 50s, it could happen to you in 40s. So how old were they when it developed? And it is very different than how old were they when they were diagnosed. Because yeah, when you find out does not mean is when you have it. When someone comes with heart attack and we see that, oh yeah, you have hypertension, diabetes, it probably developed 5 years before the heart attack was diagnosed. So things just to keep in mind and make sure you share it with your provider. So a lot of information that we shared, just few things that I want top takeaways from this. Diabetes screening, it starts young, does not matter. You're 40, you're 50, no, it starts young. These are the normal thresholds, normal cutoffs, your A1C levels, less than 5.7. But we have noticed, again, yes, don't ignore your A1C level. If your doctor tells you you're pre-diabetes, take it very seriously because from 5.7 to 6.4 in 3 months, it can happen drastically. Studies have shown that just a little higher than 5%, which clearly are not abnormal in our current lab status, but for South Asians, these are enough to cause heart problems. So your A1C level could just be 5.6. It is not going to flag, it's going to be normal. Even if it's 5.7, it's going to be normal. But with all the other risk factors, I would still be careful. Now, what is a normal threshold? We don't know yet, but lower it is, better it is. Maybe 5.2, maybe 5.4. Unfortunately, we don't have studies to prove, but definitely if you are in pre-diabetes or diabetes range, you have to work on getting these numbers much, much better. Move, move, move. Well, our guidelines clearly recommend for everyone, this is not any different to a South Asian, but 30 minutes, 5 days a week, 150 minutes a week. Standard thing I tell all my patients. Yes, we have a lot of work from home situations. We have a lot of working moms. We have a lot of other things in mind. Honestly, I'm culprit for this too. Every day you decide, oh, I'm going to work out for 30 minutes. It's really hard with the life we have, but this is something we have to do for ourselves. Same things that, I hear all the time. I've seen a few family members. Oh yeah, you're not obese, you should be fine. Oh, you don't need to exercise. You don't have you seen my visceral fat? No, what you're seeing is subcutaneous fat. So your risk is still much higher. The fat stores are deep within your body, things that you cannot see. So working out would not be for that subcutaneous fat, it's for these deep stores that you cannot do anything. Typical meal that we all love, I'm probably going to have one tonight too, but these are the things that we eat. Problem happens when East meets West. What is this? We have our own patterns of food. A lot of carbohydrates, love chapati, love rice, love naan. Lentils, yes, they have good source of proteins, but also have a lot of complex carbohydrates. We eat ghee. Oh, ghee is good for your bones. Ghee is good for growing children. We have a lot of butter. Most of us are vegetarian. We don't have a good, like all the lean meats, like even if we eat, it's goat and those kind of things. Along with that, now we are here. We are, in the country of abundance. So we see a lot of dairy, we see a lot of fried food, we see pizza, pasta, potatoes. So this is where our culture meets the Western culture, and both together, it's just a setup for failure. So I like to say when the East meets West, that's a disaster. Things that we can just keep in our mind when we are serving ourselves, our dinner, lunch, whatever. More than half definitely needs to be vegetables. A little bit portion can be fruits. You can combine this in half and say half of it should be all the vitamins and minerals, that's fruits and vegetables. Half should be whole grains. And whole grains would be whole wheat, or chapati. You can have brown rice. Nothing should be refined. No refined flour. No white rice. No white bread. Yes, we all love dosas, but limit that. It all comes in whole grains. And then there's healthy protein, which if you're vegetarian, you're stuck with beans, you're stuck with nuts. If you eat a lot of fish, it comes here, which is really good. And of course, you avoid all the processed stuff. And then healthy oils would be, olive oil. And you limit the amount of salt, you limit the amount of butter, ghee, and plenty of water. So just to have a mental picture, whenever you're serving yourself, is half of my plate fruits and vegetables? Yes, of course, fruits you have to limit because they come with their sugars too. Is less than half. So is it more like 1/4 of my plate? Whole grains, which includes your chapati. So have one chapati with half the plate vegetables. If you're having chapati, then cut down on the rice you're eating. And then does 1/4 of my plate have protein? At least, vegetables, half with brightly colored vegetables. Proteins, we talk about edamame, actually pretty good source. Tofu, we have kidney beans, pinto, black beans, lentils. We have a bunch of these varieties. Fat, always think about the healthier option, extra virgin olive oil, which actually I've been using for the last 2 to 3 months for my daily cooking. Yes, it burns pretty quick, but I don't feel any different in whatever I'm cooking. So if you can just use that for your daily cooking, that's best. Avocado oil, avocado slices, nuts, avocado, these are all HDL. These increase your HDL. They increase your good fat. Fiber-rich grains, so brown rice, and there's wild rice, and there's quinoa, and then green peas, sweet potato, don't take their skin out. And then healthy dairy alternatives, which I've written, but unfortunately that's going to be very difficult for a lot of South Asians, including me, to adopt to use soy milk and almond milk. I mean, we are so fond of our tea and coffee that it's going to be a little difficult. But you can at least use 1% or zero fat milk. All right, coming to our risk factor summary. Again, this is going to be a little more medical stuff, but I think we have hammered it enough that now you guys will be familiar. Yes, we have high prevalence of diabetes. We have impaired glucose tolerance, meaning our body does not know how to use all that extra glucose because of insulin sensitivity, which is all related to the high fat. Body does not know how to use insulin. We have triglycerides are high, our HDL levels, which is the good cholesterol, that is low. Obese, overweight, yes. Remember the lower BMI cutoff? We have that. Hypertension, use of tobacco products. I don't know how prevalent it is around where you guys are, but I recently went to India, but actually last month, and I'm from Gujarat. Every other person I saw had some form of tobacco product in their mouth. It amazed me how, yes, we've, I mean, it might not be very common, but I was amazed how everyone had red teeth and red mouth, and they absolutely love pan and tobacco and supari and those kind of things. Low physical activity, yes, we love to sit down and watch TV. We have family history of coronary artery disease. Good to know the family history. You need to know the status, what your generations are, siblings, anyone. And, our traditional, the East meets West, the diet. So we constitute 25% of the world population. 60% of the heart disease comes from us, which is probably the highest. We develop heart disease 10 years earlier compared to everyone else. Little less than half their normal weight, but they have more than 2 risk factors. There's high prevalence of diabetes, blood pressure, cholesterol, and most important, 40% chance of dying from heart disease compared to anyone else. This is something, yes, if you present with a heart attack, people put in stents, you're saved. But for whatever reason, based on Masala study, there's one other study in which thousands of South Asians, Masala did not have anyone with events, but there was just a little extension of that study that was done on people with heart events. And compared to anyone else, those who presented with heart attack, 40% higher chances of mortality, meaning 40% higher chances of dying than anyone else with heart disease. Well, so I have a little women's heart and prevention clinic with Ascension. As Sunita pointed out, I, along with all the pregnancy, menopausal, those kind of, I definitely am keen and fond of treating South Asians, people like me, even if they don't have a high family history, but who have risk factors or even who want to be screened for risk factors. What are my chances of having heart disease in 10 years? The medicine is so advanced that we definitely can do all the screening and risk assessment, which is not 100%, but it is very close to 90%. And just like to thank you all for being here and spending your weekend with me.
Thank you. Yeah, that was incredible information, especially on this Heart Month that we celebrate in February. The statistics are crazy about South Asian people and the cardiovascular risk. It's scary, actually. We do already a couple of questions. This is from Rajneesh Kiran. Rajneesh, do you want to ask yourself? Unmute yourself if you want to talk to her directly, or I can ask too.
Yeah, you can ask. Go ahead, Gigi.
So Rajneesh Kiran is actually our yoga instructor. He has been serving the wellness team selflessly for many years. He's very actively involved in many of our wellness initiative. And he has some questions, as you all see. He was asking, is there a way to recognize, diagnose fatty streak? Are they reversible? This is his first question.
So fatty streak to diagnose, unfortunately, no, because we have coronary calcium score, which looks at the calcium. It's, when you have the fat, macrophage, and the calcium, that's the only thing we can see. There's no way to diagnose a fatty streak, but that is the most reversible part. So hopefully in the next few years, I'm sure there will be a way in which we can diagnose the fatty streaks as well. But as of now, no, we don't have any testing for that.
And Rajneesh also has another question. Is coconut oil safe to use to prevent, or what type of oil can we use in cooking to prevent fatty streaks?
Unfortunately, coconut oil, just like ghee and all the canola and vegetable oils, these are all saturated ones. And yes, you can use it in moderation, just like I tell all my patients, if it is something you cannot forego. But the only two oils have actually been very, very helpful and studied are the avocado oil and the olive oil. So, you find a lot of extra virgin with blended olive oils. These are the ones you can definitely use for cooking, because then they don't, what do you call, like with temperatures, they're not that sensitive as extra virgin olive oil. So you can still cook with them. But coconut oil, I mean, if it is something you definitely cannot go without, then just very little compared to what, you think your food would. But definitely fried foods are a no-no. So it doesn't matter what oil you use. Yeah.
All right. Any audience, any more questions? This is the time you can ask.
Yeah, this is Rama. Can you hear me, Sunita?
Yes, Rama.
Yeah,
You can.
thanks for forwarding me this invitation. Yes, and thank you, doctor, for your time and a really good presentation. The question, I think, part of the first question, or maybe extension of that question. So you mentioned that obesity are two types. One is external body fat and internal body fat. And so maybe you might have answered this question or not, but just want to clarify on that. Is there any way we can find the internal fat? Are there any tests that we can be done to find out? And how can we get the treatment done for that?
That's a very good question. When we do echocardiograms, ultrasound, we can definitely see the internal fat around the heart. It just appears, like there's a big fatty blob outside the heart. So that would be the only one that I can think at the top of my head in which we can see the fat, the visceral fat, the internal fat. Otherwise, around the liver and those things, it's very hard. I mean, you can have a full fat scan and in which they diagnose, but is it something in guidelines? Would your physician do that just for this? I don't think so. They usually focus more on the external fat. If they're doing, echocardiogram, ultrasound for some other reason and they find this, then definitely to keep in mind.
Mm-hmm. And one other question I have is that, I'm free to share my health issue here so that, you'll get some idea. So I've been doing exercises like, I love doing Zumba and I go to gym and everything. But within BMI, I have no issues. But the thing is that when I go for annual checkup, my cholesterol level actually always in red. So that actually little concern. So I've been seeing that from past few years, but finally my PCP prescribed, the cholesterol controlled the medicine daily that I'm taking. So that is only the way that we need to follow. Is there any other way we can, like as you mentioned, the hereditary from our South Asian community, the way how we our body built, or maybe how we born, maybe that's how it is. So is there any suggestions on that, like, what we can do?
So that's good that you're good with your diet. I mean, with your exercise. How is your diet? Let me ask you that. Do you think you fall in the very good category, or you think you're good, or still you think there are things that you can be better at?
Exercise, actually, I'm doing regular every week. Very good, actually. I'm doing some body pump classes in YMCA. I'm also taking Zumba classes, and yes, I'm good with that. So, are you talking? Is this question related to the diet? Okay. So, diet, actually, last year, actually, what I did is I cut down rice. Whenever I go to friends' place and parties, I'm eating rice, but I was not eating a big amount of rice. But this year, actually, from January 1st onwards, I stopped eating rice. I'm eating quinoa and, with curries and those kind of things. And also I cut down completely milk this year. I'm just drinking only oat milk this year. So that, I'm fan of, like, coffee drinker. So I don't want to give up that taste, so that, but it was hard this year to cut down the coffee with adding sugar. But this actually took me 1 year to get adjusted to the taste, like oat milk with coffee, filter coffee. And then now I'm balanced and, got used to it.
So it seems like you're doing really good with both diet and exercise. So unfortunately, the only way that, your numbers would be better would be a medication. I know a lot of people, I mean, you actually brought up a good point that I'm going to, emphasize during this talk. I prescribe statins to my patients. Statins are the medicine for cholesterol. I mean, Sunita and I would both agree that these are cardiologists' best friends. These are the medicines that are, when you look up online, you'll be shocked and you're like, why are these medicines even here? They would say so many side effects and how bad they are, and they cause diabetes, and they cause dementia, and they cause yada yada yada, things that are really bad. But these are the only medicines that actually, amongst all the medicines, including baby aspirin, these are the ones that are top of the list to prevent heart disease, to prevent you from dying, to prevent from heart attack. So if you are on a cholesterol medicine that's helping your numbers and you're so good with everything, I would just take it. I don't think it is you or your fault in which, why your numbers are that bad. It's unfortunately just the genetic makeup and things that are not under your control. But having said that, when you're in this, on this cholesterol medicine, don't ease up on the other part, like don't think that, oh, I should stop working out or not eat. Like continue that along with the medicine and just get the most of the medicine.
Thank you very much. Thanks for your time.
Of course.
Good questions, Rama, and thank you for coming forward with the questions. And Dr. Shaila Shah, we have a few more questions from Sri Lekha. She was asking us, how do you know if you have visceral fat and how to lose it? That is her one question. And she has two more questions also. So we'll answer this then.
So visceral fat is not something you would be able to know otherwise unless you get some sort of dedicated study for other reason, like if you're having, and ultrasound of the heart, ultrasound of the liver, and it mentions in your report, which again, people don't emphasize because they don't deal with South Asians, that there's a prominent fatty streak or there's fatty thing, you wouldn't know, or unless you have some surgery and they open you up, which we don't want to know like that. There's no way to know, and there's no way to prevent, because it is something that would not be under your control. What is under your control is just the outside body fat. But the thing that definitely helps with the visceral fat is to make sure that you definitely don't have the outside, the subcutaneous fat. If you have that outside fat, definitely you have a lot of inside fat, if that makes sense. So if you, what is it under your control is what you see outside, and make sure you're good with all that. You probably won't be able to know what's inside unless you get some testing done for some other reasons.
Exactly. And Sri Lekha was also asking, how many eggs a day or week are ideal, and is coffee bad for heart?
coffee is not bad for heart. There are still like, there are studies which will say coffee is really good for your heart, coffee is really bad for your heart. The only thing that coffee does is, it causes a lot of sympathetic activation. I see a lot of women come in with palpitations and, oh, I feel my heart going too fast. I feel my heart skipping beats. If you are one of them, then coffee is not your friend. These females or these patients, they skip coffee and perfectly fine. And coming to eggs, one egg, complete egg, one a day, but you don't have to limit the egg whites. So if you are eating, let's say 5 eggs a day, if it's all egg white and just one yolk, that's perfect because one yolk gives you the amount of cholesterol for the whole body. But as many number of whites as you want. There's, of course, everything in moderation, but I wouldn't use a complete egg more than one. So
all right, Dr. Shailisha, we have one more question. So this is from one of the Manofa member. She's asking premature symptoms of cardiac arrest that we need to watch.
Cardiac arrest would be a little later, but yes, premature symptoms of heart attack would be you are limited in your daily activities. I mean, of course, yes, if you're not walking, you would be deconditioned and you won't be able to run a marathon in day one, but you're doing this on daily basis and you feel like all of a sudden you're getting too tired, you cannot do things that you were able to do before. You feel like you are more short of breath, even though you don't have cough, cold, or any other symptoms. If you feel like you've noticed that a lot of times I'm having, some tingling in my arms, I'm having some heaviness in my shoulder, my jaw, then these are the things. Or if you feel like whenever you're exerting. So most of the symptoms you have to think about are exertional because that's when your body needs more blood. And that's when you would, start having more symptoms. So it's exertional shortness of breath, exertional indigestion, exertional heaviness in your chest, like or shoulder tingling. So these are the things you definitely need to watch for. And then breaking out in sweats. Oh, I just walked to the mailbox and God, I was like all sweating.
This question was from Simple, one of our Manofa secretary for 23-24. So Dr. Shah, you were mentioning that it's not the old age which is predisposing one to cardiac conditions. Even the cardiac situation or cardiac symptoms can show up as early as 18 years of age. So ideally, at what age in teens do you recommend screening for cholesterol?
So now the guidelines have changed, and even like people as young as 25 years, when they go to their primary care, they get a full lipid panel. If everything is perfectly fine when you are in your like early 20s and your family, you have good genes, no one have, any risk factors, it's okay to just do it every 10 years to keep an eye on it. But if you know that someone in your family has, had a heart attack in their 40s or like stroke or hypertension at an early age, then I would definitely do not like every 10 years. You start at like 25, but then you don't, you do it every 2-3 years just to keep an eye that you are within the normal range. Awesome. So as early 20s, that's perfectly fine. And of course, there are some hereditary cholesterol abnormalities. Again, South Asians, it's not very common, but then there's, you're born with those genes that prevent, so there's this bad cholesterol LDL that is cleared by the liver. So you're born with those genetic problems in which that bad cholesterol cannot be cleared by the liver and it just accumulates. So people as young as 3 or 4 years old, I mean, kids that age, they can have it, but you would have a family history in that. So, I mean, your parents would know that, like, oh yeah, at a younger age, I have it. And those kids, even like 4 or 5 years. But yeah, for most of normal people, it's like around 25, you should definitely get your first cholesterol check, and then depending on how you are, either 10 years or every 2 to 3 years, just to keep an eye.
We have a raised hand from Dr. Babu Balagopal, and he will be asking you the question. Babu Cheta, go ahead.
Yeah, thanks, Vinita. First of all, I just wanted to really, thank Dr. Shah for that excellent overview of the cardiovascular risk in South Asians. That was really excellent in the short time span. And before I get to my question, I would like to congratulate Indu and Manofa for organizing this seminar, and Sunita for really moderating very well as always. So, Dr. Shah, my question is, I'm sure you are aware of this, and you mentioned about this the disparity in insulin resistance in South Asians compared to Caucasians. And if I remember correctly, there was a paper maybe a decade ago. Few of the South Asians were co-authors in that paper, like Manisha Chandalia, a good friend, and Sridevi Devaraj, and Iswarlal Jialal, and along with, of course, the guru of cardiology, Scottam Grundy. But what they found was insulin resistance and inflammation. Especially they looked at high sensitivity C-reactive protein, and what they found was the difference in adiposity in Asians, whether it is visceral or subcutaneous. That doesn't completely explain the difference in insulin resistance and inflammation. So, do you think muscle plays a bigger role than fat, especially in South Asians? That's my first question. And the second.
Hold on. Sorry, can you repeat your first question? Do you think?
Do you think muscle plays a bigger role than fat in South Asians? Because we South Asians, our body composition is different from Caucasians. Muscle mass is, typically low, and there is evidence to show that there is sarcopenia early in people from South Asia. So, shall I go to the second question, or?
I can probably answer the first one, and then we can go to the second one. That's actually a very good observation, and I know about the study that you're referring to. That's very true. Again, a lot of things are unknown about South Asians, and now, with all these randomized studies that will hopefully have more information. As far as whether muscle mass, sarcopenia, yes, but the opposite is also true. I know, like when, recently few cinema stars, they died. There was this whole thing going on social media, tweets and everything. Oh, don't go to the gym. All that muscle that you build up, that causes heart attacks. So there's just so much out there. And unless you have a significant hypertrophy, like very thick heart muscle that's obstructing the flow, having low muscle, I don't know if that is surely, a culprit. Does a low muscle mass means that you have high fat content? Maybe if that's related. But I'm not aware about the relationship between muscle mass and, heart problems. That's something that's definitely a really good observation, and I should probably, I'll look it up, but there's nothing that I'm aware of it at the top of my head.
Thank you. And the second question is relatively new. My question is the history of COVID-19 a risk factor for cardiovascular disease? I know that it's too soon for guidelines to come out, but what's the current practice Do you look at that? Or if someone comes to your clinic with a history of COVID, how do you look at them compared to other people? Having said that, I know that most of the people in the US already have COVID.
That's again a very good question. Actually, I did COVID-19 and heart disease as a part of one of my fellowship talks, and there's a lot out there, but the studies that actually, like true, people dying and those having autopsies, there's no correlation of them having any heart disease yet. There were like, I think 5 people in China, they had a heart attack and all from COVID-19. And then they looked it up and there was nothing that they found to suggest that they have inflammation in their heart from COVID. There was no myocarditis or anything that they found. The other thing, COVID and even the vaccines, now it's bringing up a lot of other autoimmune conditions. Now, all these autoimmune in which your body, basically just for everyone else, autoimmune diseases are those in which your body, normally our body knows what are bad cells, what are good cells, and here your body just tries to eat up your own cells. And depending on what organ, you could have, any sort of symptoms. So COVID with a lot of autoimmune conditions have been kind of starting to come up. How that is directly going to affect the heart, we don't have that much information, but does that cause premature atherosclerosis, meaning like premature blockages, premature heart attacks? So far, it hasn't come up, but would it be something that would be worthwhile and, worth seeing in future? Absolutely. I think 5 to 10 years down the line, when we have more and more, information, things will come up. But right now, I haven't seen people have this long COVID syndrome in which they're deconditioned and short of breath. But per se, like when, do a heart cath or do these guys have heart attacks at an early age? There's not much out there for that. There are people who are already at risk based on their risk factors and everything, and COVID just being an additional stress to your heart. There's something called stress-induced heart attack, meaning like you are a good setup with, hypertension, diabetes, whatever other things, and then you have COVID-19 and it's just too much for your body to take, too much for your heart to fight. In that, yes, you have a cardiac arrest. Is it from COVID? I'm not sure. If it was perfectly healthy, fine, 20-year-old dying with a heart attack, then that would be yes, from COVID. So maybe it exaggerates things. But does it truly cause heart events? Nothing has come out to suggest that yet.
Thank you. The reason I asked that question was because COVID, it's basically an inflammatory storm.
Yeah.
And it elevates the inflammatory state.
Right.
And heart disease, as you will agree, it's an inflammatory disease. So I agree with you. We don't have enough studies, but there are a lot of studies coming out showing that the inflammatory state is not coming back to normalcy or whatever is supposed to be. So that may accelerate the development of cardiovascular disease and probably heart attack. I don't know. So I think I agree with you. Thanks very much for that great talk, and I'm so happy that a cardiologist giving a talk focusing on lifestyle changes rather than pharmacotherapy. Thank you.
Absolutely, my pleasure.
Thank you.
Dr. Babu Balagopal, he has extensive experience in research. He does a lot of research studies and he works for Nemours. So he will help. We had a great talk with him at the last seminar that we had last year. Thank you, Avcheda, for all your excellent questions. And thank you, Dr. Shah. And we have a couple of questions more lined up. This is from Reshma. She's a very active player of Manofa. She is asking, after taking cholesterol medication regularly, for 3 to 6 months. Once the cholesterol is normal, can we stop it eventually, or can we reduce the frequency of medicine?
So typically how it works, when my patients come in and, their bad cholesterol, just to give you a number, it should be definitely, less than 100, less than 70. And I said the European guidelines less than 50. So if you were like 120, and then after starting the medicine, let's say you were 60, that's like a robust response for me. In that case, I try to just do it every other day and see how you do. Because to be honest, a lot of patients have at the back of our mind, the cholesterol medicine is doing its job. So I can, take that ease and, eat what I can, what I want, because my numbers look good. You have such a mental thing that, oh yeah, my numbers look great. I can eat anything and I'm already on a medicine that's taking care of it. But if you're, like one of those patients, one of the people that we recently spoke who's really vigilant with diet and exercise, and despite that your numbers are really low, I mean, it would be reasonable to just back off, do every other day. I've had patients just do it like Monday, Friday, like 2 days. Some people just do it as they want. And you just monitor. Some people, yes, you stop it, but then you have to be very good with the risk factor control, making sure you check your labs. And if you see the uptrend, you just resume it back. But there's just a variety of ways you can play with this. Does not mean that you have to be on the same dose, same duration for the rest of your life.
Thank you, Dr. Shah. That was a good question. Yes, we can take some break if it is normalized with continued lifestyle modification. Thank you. And next question is from Celine Enajuman. They're asking, does intermittent fasting helps with the fat loss and help with the cardiovascular health?
Fat loss, yes. Cardiovascular health, I'm not very sure, because the common notion is when you're intermittent fasting, you're not eating anything, but in whatever, depending on, how many hours you're doing, but in the 8-hour eating period, you can eat whatever you want. And some people mix that with keto, and then that all is not good. But if you are doing intermittent fasting with a low carb meal, yes, definitely it's going to reduce your fat and it's going to help you with the heart problems, not on its own. So yes, if you're intermittent fasting and still eating normally, still eating, like the good amounts of chapati rice, all the good carbs and everything, then it's probably might reduce a little bit of your fat, but it's not going to help much.
Awesome. Thank you. Next question is from Nisha to Dr. Shah. With the pandemic, we are seeing more respiratory issues, and how does this affect the heart and how to prevent those?
How to prevent those? Not sure. Yeah, I just had a good discussion with Dr. Babu Balagopal about the pandemic and heart disease. Definitely, as we spoke, there's a lot of inflammation, there's a lot of stress. If you have the risk factors, things can be triggered. Has it caused people to die from a heart attacks or anything like that? We don't have enough information yet. Nothing suggests as of now, but then these are studies that would take like 5 to 10 years. And I'm not aware of any recent study. How to prevent that? Again, the same risk factor modification that we kept on emphasizing. Make sure you're not a pre-diabetic. Your A1C levels are way closer to 5 than be, north of 6. Make sure that your BMI cutoff is much, much lower, in the sense, even if you are 23, you could be a little obese, which of course your primary care wouldn't say that, but that's us South Asian. Make sure your bad cholesterol is less than 70, your triglycerides are lower, you're following a good diet, you're walking for 30 minutes every day. These are all the preventive measures. Doesn't matter if it's COVID-19 or if it's influenza or any other virus you would have, but these are, the things that you can do to prevent any sort of cardiovascular event. And of course, if things are not under your control, you're doing all that. And if your doctor prescribes you